Hi and welcome to this multimedia video tutorial on acute pancreatitis. We're not just going to help you answer the questions on acute pancreatitis in the exam, but also how to be a good doctor as well. So we're going to cover what are the basic functions of the pancreas, why do people get pancreatitis, how do patients present in terms of their history and examination findings, what investigations do you need to do and what do you need to know about, how are you going to manage these patients, and we're going to talk about the further management as well so that you have an understanding of that too. And then we'll talk about the prognosis and complications before wrapping things up at the end. The pancreas is an endocrine and exocrine gland that resides in the retroperitoneum. Its head lies adjacent to the duodenum at the level of L1, and its tail points towards the hilum of the spleen. The exocrine function of the pancreas is to secrete enzymes such as lipases and amylases into the duodenum for digestion via the main pancreatic duct and the ampulla of Vater. The endocrine function is glycemic control. The alpha islet cells secrete glucagon and the beta islet cells secrete insulin. Importantly, the pancreas secretes lots of bicarbonate in order to increase the pH of the duodenal chyme, and this has an important effect on the acid-base balance of the blood. So what causes pancreatitis? Well, this is the mnemonic, get smashed. You need to know this, so if you need to, pause the video and have a look through this. We'll touch on a few of these now. The most important causes that account for 80% of all cases of acute pancreatitis is gallstones and alcohol. Alcohol is your most common cause of chronic pancreatitis, and these are the patients who come in and out with acute and chronic attacks of pancreatitis. So acute pancreatitis, gallstones and alcohol. We'll touch on a few more causes. So ERCP, around 5% give or take of patients who have an ERCP, that's your endoscopic retrograde cholangiopancreatography. Around 5% of these patients may go on to develop acute pancreatitis, and I think it's usually within a couple of days of the procedure. Important causes, also medications. There are quite a few medications that can cause pancreatitis. I haven't listed all of them, but I've seen cases of a child on valproate with acute pancreatitis. Steroids is obviously important, so it's got its own letter. Basically, when you see a patient with pancreatitis and you're not sure what the cause is, have a closer look at their medications, look it up in the BNF or whatever is equivalent, and see if that medication has the potential to cause your patient's pancreatitis. A personal favourite of mine, hyperlipidemia. I've seen this a few times. Patients come in, sometimes looking rigid, peritonitic, like they've perforated something. And you send off some bloods to the lab. You may even have noticed that the blood looks a bit milky. And the lab says, sorry, we can't process the biochemistry test because the sample is too lipemic. So if the patient has a lipemic blood sample, that you can't get an amylase to traditionally make your diagnosis, and you've got a person with abdominal pain, then have a very high suspicion for acute pancreatitis. So what kind of things might we get from the history? Well, generally a patient with pancreatitis complains of epigastric pain radiating through to the back, sometimes relieved on leaning forward. There may be non-specific features as well, such as nausea and vomiting commonly, also loss of appetite, and if things are getting particularly bad, there may be some abdominal bloating they might be complaining of if they've got a bit of an ileus as well. They also may have some fevers, so it's important to ask. In terms of questions that you need to ask to get the extra points, ask them questions that might lead to the cause of their pancreatitis. So, is there any weight loss, i.e. is there malignancy as a cause, a tumour of the pancreas? Do they have a known history of gallstones as examples? Also in the social history, ask them how much alcohol they drink. Now we also need to look and consider other differential diagnoses, especially if you want to get those extra points and not miss anything when you qualify as a doctor. So these important ones are perforated ulcers. So a perforated peptic ulcer may present very similarly to a person with pancreatitis, and you don't want to miss them. So ask things pertinent to risk factors of peptic ulcer disease. There's things like, are they taking NSAIDs? They have a previous history of peptic ulcer disease, and other risk factors include smoking, of course. And also ask them if they have a history of dyspepsia, some retrosternal burning. Obviously, don't word it like that. Another important differential diagnosis that you need to suspect in anybody that comes in with abdominal pain, particularly if back pain is involved. And can you guess what it is? Yeah, abdominal aortic aneurysm. So it just simply asks them, do they have a history of an abdominal aortic aneurysm? They may look at you like you're crazy, or they may say, oh yes, actually I've got one. Oh, by the way, it's 8.5 centimetres or something ridiculous. So that's also really important. So ask specific features, non-specific features, questions to look at the etiology, and questions to consider differential diagnoses. So what about examination findings? Well, firstly you need to have a look at the patient from the end of the bed and decide if they're well or unwell. So observations for someone with acute pancreatitis can vary from somebody who's pretty well to somebody who's seriously sick. If you look at the bottom row, you'll see I've written SIRS 2 points. So that's systemic inflammatory response syndrome, and you need to have 2 of the following criteria to meet that. So if you've got someone with a pulse of 140 and a blood pressure of 70 systolic, then they automatically qualify as having systemic inflammatory response syndrome. And these are the patients you really need to get help very, very early on. So when you approach the patient, you've determined whether they're well or unwell, and if there's anything you still need to do to stabilise this patient. Have a look at the sclera, the skin, see if they're jaundiced, and then move towards the abdomen. And on examination, you're going to find perhaps that all of the upper abdomen is tender, but they may be maximally tender in the epigastrium. So epigastric tenderness. There may be signs of peritonism, and by peritonism I of course mean guarding, percussion tenderness, and or rebound tenderness. These may also be present. What else might you find? Well, if they've got particularly bad pancreatitis, you may find you've got it Gray-Turner's or Cullen sign. So Gray-Turner's, now I remember this because Gray-Turner has 2 words and you have 2 flanks, so the left and the right. So this is your Gray-Turner sign, so flank bruising, as blood from a kind of a hemorrhagic pancreatitis tracks around the abdominal wall posteriorly to laterally, and then you can see all that bruising under the skin. And Cullen sign, Cullen, that's 1 word, and you have 1 umbilicus. That's bruising around the umbilicus. Now if you see these, then that's generally a bad sign that this patient's got pretty bad pancreatitis. So at the beginning of your investigations, when you're clocking the patient, there are 6 key tests that you need to consider. And this is for any patient in really any scenario that you see, because these are simple tests, and if you don't do them, you should have a good reason as to why you haven't considered it. Here we go. So don't forget these. Related to acute pancreatitis, we'll start with a capillary blood glucose, and this can go up in pancreatitis, and you need to decide whether you need to put this patient on an insulin sliding scale regimen. ECG is important as a baseline because things can go wrong during the patient's stay, but also if they're tachycardic, then you need to decide if it's a sinus tachycardia or if there's actually an arrhythmia and there's something else you might need to do. Furthermore, if a patient is having epigastric pain, this may not be pancreatitis, it may be an MI, and you really don't want to miss that. Urine dip is important to have a look at other causes of abdominal back pain, such as renal calculi pyelonephritis. Blood tests will have a look in a bit more detail in the following section of the tutorial. You need to consider an arterial blood gas to get a pH, to see if the patient is acidotic, and also to have a look at the respiratory function, as respiratory complications in patients with acute pancreatitis are not uncommon. The PaO2 forms a part of the modified Glasgow score as well. In terms of venous blood gases, this is if you want quick serial measurements of lactates and bicarbonates, for example. Looking at X-rays, now an erect chest X-ray will miss a lot of patients with a perforated intra-abdominal viscus, such as a peptic ulcer, but you still need to do one, because if it's there, then you've got your diagnosis and you need to act quickly. So do an erect chest X-ray to look for air under the diaphragm. Also have a look at the lung fields, again, to see if there's any radiographic evidence of respiratory complications. An abdominal film will look for abdominal complications such as an ileus, or it may give you the clue as to another diagnosis. Okay, so let's look at the blood tests a bit more closely. What might we see? Well, raised inflammatory markers, so a raised white cell count and raised CRP. UNEs, renal function, might be deteriorated, so we might get a raised urea creatinine. Okay, creatinine and urea. And also have a look at the electrolytes. Now, why might the UNEs go off? Why might the renal function go off? Well, for a number of reasons, but mainly because of dehydration and pre-renal failure. So hypotension leading to tissue hyperperfusion, including the kidneys. So that's why it's so important to keep patients with acute pancreatitis adequately hydrated so they can perfuse their kidneys. LFTs. You may see an obstructive picture if there is an obstruction at the ampulla of vata that's giving you your pancreatitis. What I'm referring to is gallstone. Tumour can do this too. So if you have a gallstone or an obstruction at the ampulla of vata, where the common bile duct meets the main pancreatic duct before going into the duodenum, then this is all going to be dilated and you're going to get an obstructive looking picture in your liver function tests. So what do I mean by that? I mean a raised ALP proportionally greater than the raised transaminases, transaminases being AST and ALT, so they might be raised as well, but you'd expect to find a greater elevation of your ALP in an obstructive picture, and your bilirubin would be elevated too. Now, if this is the case, then you're expecting that your patient with pancreatitis is probably going to end up needing an ERCP to undo that blockage we talked about, to get rid of those gallstones and extract them, and that would require a sphincterotomy. The sphincter of Oddi at the ampulla will need to be cut. So you need to make sure that if this patient is going to go for an ERCP, the coagulation profile is acceptable. Okay, so you want an INR. Also, the INR and the APTT, the coagulation screening tests, may be deranged due to sepsis and SIRS, or there may be nutritional factors. Now, amylase, here's the big test to get your diagnosis of pancreatitis, and to do this you need an amylase that is greater than 3 times the upper limit of normal. Okay, amylase greater than 3 times the upper limit of normal, that's almost certainly your diagnosis of acute pancreatitis. You can get raised amylases in other situations, usually not so high. An important one is perforated peptic ulcers. Okay, now in a patient with chronic pancreatitis who's getting repeat attacks of pancreatitis, for example your alcoholic that comes in with more epigastric pain, you may not see a rise in the amylase, but they still might have pancreatitis, and you should always bear that in mind, someone whom you clinically think might have pancreatitis. Calcium. There are a number of reasons why calcium might go down in pancreatitis. These include calcium crystallizing in the pancreas, particularly if there is necrosis involved, and that brings the serum calcium down. Also changes in your albumin concentrations, secretion of PTH, and don't worry about all that. Just try and remember that the calcium can go down, and also that forms part of the scoring system we're going to talk about a bit later on. LDH, and the only reason I've mentioned this is because it forms part of the modified Glasgow score, again, which we're going to talk about. So, and this may go up. Okay, so here we are, blood tests. Let's move on to scoring systems. So as part of the investigations, when I see a patient with acute pancreatitis, I want to make sure that we've done the investigation so that we can complete the modified Glasgow score, or any other score that you fancy using. But that's why it's in this section, so let's talk a bit about that. So the modified Glasgow score is one of a number of different scoring systems that you can use in pancreatitis in order to grade the severity. So I use the modified Glasgow score partly because in places that I work, that's what everybody else uses, so we're all talking the same language, and also because a mnemonic's involved, and we all love mnemonics. And this one is aptly called Pancreas. So it's 1 point per letter. And just as a note, if you have an AST above the threshold or an LDH above the threshold, that's 1 point. And if you have them both above the threshold, that's also just 1 point. We'll talk about what the actual score means a little bit later, but another point to note is also that modified Glasgow score is applicable to both gallstone and alcoholic pancreatitis, and the applicability of these scores in this way is something you need to consider when using them. So that's covered what you can do as a junior doctor and the answers you can give in an exam, but what do you need to know about? Well, this is about further imaging, so let's have a look at that. Generally speaking, all patients with acute pancreatitis should have an ultrasound scan to see if there are any gallstones, also to see if there's any biliary tree dilatation, which might suggest in a patient with acute pancreatitis that there may be a stone or other obstruction at the ampulla of Vater. So an MRCP is essentially an MRI scan looking at the biliary tree. So after an ultrasound scan, if there's doubt as to whether or not there's obstruction of the CBD that might be causing the acute pancreatitis, then an MRCP can be performed. The first thing to say about CT is that it can look normal within 48 hours of onset of symptoms in somebody with acute pancreatitis, so we generally don't tend to use it to diagnose the condition. Instead, we can use CT to exclude important differentials such as a perforated peptic ulcer. Another reason to use CT is if a patient deteriorates during his or her inpatient stay with acute pancreatitis, then we need to see if there is a complication of the pancreatitis that may be responsible for that. For example, a necrotic, infected pancreas, or maybe an abscess, and these are things that we would then need to do something about. Every time you get asked a question on how to manage so-and-so scenario, the correct answer is always ABCD approach. And then you can go on and talk about disease or condition-specific management. So ABCD approach, and that's how we're going to start when we now treat our patient here, Johnny, who unfortunately has got acute pancreatitis and is very sad. So we need to try and make him a bit better. So let's just concentrate on the sort of management aspects of ABCD. A, he's got a patent airway because he's very unhappy and is complaining about his pain. So B, let's talk about B. So first thing to do, pancreatitis patient, Johnny here needs some oxygen. So let's put some oxygen on him. There we go. B, I'm also going to talk about analgesia in B, because obviously we want to make the patient comfortable. But if these patients aren't adequately analgesed and they've got a lot of pain when they take a deep breath in, then their ventilatory function is going to suffer, and they'll have lots of atelectasis. Parts of their lung will shut down essentially, and they'll be susceptible to pneumonias. Okay, so analgesia I'm going to put here as well. So let's have here some morphine. There we go. For our patient, we can give this IV or IM, but the point I'm trying to make here is don't be afraid. These patients may be in a lot of pain and you want to try and get rid of it. So moving on to C for circulation, you've got it. Fluids. It's difficult to overstate the importance of IV fluids in a patient with pancreatitis. They can become very, very dehydrated. There are lots of reasons for this, but just think, pancreatitis is a systemic inflammatory condition. It's not just about the pancreas, it's about the effects on the whole body and also the vasculature. So capillaries and vessels can become very, very leaky, and fluid then leaks out into the third spaces. So into the extracellular sort of tissue matrix, into the small bowel, if there's an ileus, fluid just leaks into the lumen. In the retroperitoneum and directly around the pancreas, lots of fluid can sequester around the retroperitoneum. So these patients become very, very dehydrated. So for that reason, we're going to give lots and lots of IV fluids. IV fluids, and I'm not going to talk about which or how much. This is a topic for another tutorial, I think. But suffice to say, it is very important and we need lots of it. So there we go, he's getting IV fluids. Well, if he's getting IV fluids, we're worried about hypotension and tissue hypoperfusion, then we need to see if the kidneys are working, because the kidneys are often the first thing to start going. So, yeah, catheter, I'm sorry Johnny, but we need to put a catheter in you so that we can measure your urine output, because we need to know if your kidneys start to fail. We'll be able to tell by dropping your urine output, and then we can do something very quickly to sort it out. Okay, so that's his rather large catheter, we're going to measure his urine output. That's all in C because we're talking about the circulation. Okay. Moving on to D, yes, GCS and peripheral nervous system examination. That's fine, but what I'm concerned about in the patient with pancreatitis particularly is the blood glucose, the capillary blood glucose. So if that is raised, then you need to consider an insulin sliding scale regimen. So here is your insulin, we'll write insulin here, sliding scale infusion. We can pop that in to the cannula on Johnny's arm and ask the nurse kindly to monitor not just the urine output hourly, but also the blood glucose. And even if I didn't start an insulin sliding scale, I would still want them to regularly monitor the capillary blood glucose. So just to recap, we've gone A, we've gone with A, oxygen and adequate analgesia because we're thinking about breathing here. C, circulation, put some fluids in and measure what's coming out and ensure adequate kidney perfusion. And D, we're talking about capillary blood glucose, insulin sliding scale regimen. And there is one other thing I'm going to add on to that. You can put this in B if you like because it's also to do with breathing, and that is nasogastric tube. Now not everyone with pancreatitis needs a nasogastric tube, but just say Johnny here wasn't looking as slim today as he usually does, but he's actually got a really big distended abdomen. Why has he got a distended abdomen? Because of all that inflammation going on his side has developed an ileus. So this big distended abdomen, really painful pancreas is making it really difficult for him to take deep breaths. So for the reasons I've already mentioned, we need to help him with this, and to do that we put a nasogastric tube down and try to suck off the fluid and decompress things and make it a little bit easier for him to breathe. Other things we can do in this situation, and even if there wasn't distension, is sit the patient upright to make it a bit easier for them to ventilate their lungs. So nasogastric tube, once again Johnny, we need to put more tubes in you, I'm afraid. There we go, nasogastric tube, someone's aspirating on that, okay? All the way down, there we go. So there we have it, A, B, C, D approach, and these are the things that you can do when you're clerking these patients, and these are the things that you need to tell your examiner in an OSCE. So what about the things you need to know about? Well, that's coming up right now. So the BSG Guidelines, BSG stands for the British Society of Gastroenterology, and these are guidelines on the management of pancreatitis. And in those guidelines, you can look them up on the internet, I'm sure they'll be very easy to find. In those guidelines, they talk about these aspects of management. Antibiotics are generally not indicated in acute pancreatitis, but there is debate as to whether they should be given prophylactically. Of course, antibiotics are indicated if there is evidence of locally infective complications or if there is infection somewhere else, such as a hospital-acquired pneumonia. Nutrition is very important, and patients should either be fed enterally, or if there is ileus, so the bowel's not absorbing properly, then parenterally. ERCP is indicated if there is evidence of gallstone pancreatitis in order to perform a sphincterotomy and drain the blocked ducts. And if there is evidence of significant pancreatic necrosis, for example on CT, then a fine needle aspiration to then send this to the microbiology lab to see if there's any evidence of infection can be done. And if there is evidence of infection, either on CT or through that microbiological analysis, then the patient should then go on to have either necrosectomy or debridement, or perhaps some drains might need to be placed in infected pseudocysts or abscesses. So if a patient has had an episode of gallstone pancreatitis, then the guidelines say that they should have a cholecystectomy within 2 weeks of the patient's discharge. Obviously, as long as the patient's fit enough. What kind of complications do patients with acute pancreatitis get? These can be early or late. Late complications may include things like enzyme supplements for pancreatic insufficiency and diabetes, as well as pseudocysts. But we're going to mention pseudocysts as we're now going to actually divide them into local and distant or systemic complications, because I think that's more useful to you as a junior doctor, and there's much more to talk about as well. So local complications of pancreatitis may include necrosis, as in necrotizing pancreatitis, and this necrosis can then become infected and abscesses can form in and around the pancreas. Fluid collections can occur around the pancreas, and over the course of a few weeks these can form into pseudocysts, which are cysts but not lined by epithelium, and these too can become infected to form abscesses. So when thinking about distant complications, just go through the systems. So in the lung, pleural effusions can occur. There may be adult respiratory distress syndrome as the capillaries become leaky and the alveoli may fill with fluid. Arrhythmias can occur. We've already talked about local pancreatic complications. Hypoperfusion of the liver can lead to liver failure. Renal failure can occur due to hypoperfusion. And we've already mentioned ileus earlier on in the tutorial. Disseminated intravascular coagulation, DIC, can result from the SIRS and sepsis. This is due to inappropriate activation of the coagulation cascade, leading to consumption of platelets and coagulation factors. And so the platelets can go down and the INR and APTT can go up. This leads to hemorrhage and thrombus in and around the body at the same time. So it can be catastrophic. Finally, metabolic complications include hyperglycemia and hypocalcemia. So how do these patients with acute pancreatitis do in the long run? Well, let's have another look at the modified Glasgow score, and while you're having a look at that, I'm going to tell you this. Pancreatitis can exist in a number of forms. It can be very mild. People come in with a bit of epigastric pain, amylase is elevated, maybe nausea, a little bit of vomiting, but it goes very, very, very quickly and then they get discharged home. On the other end of the scale, we have patients who are in hospital for weeks and weeks, if not longer, and can die. Quite simply, sometimes after many, many surgical operations, drains, and after suffering other complications. So this is not a condition to be taken lightly, it's very, very serious. So why do we need the modified Glasgow score? Well, if you had a look at those mortality statistics, that should hopefully give you a clue. If my junior doctor comes and presents a patient to me, this patient's got pancreatitis, and I say, what's their score? And they say 4, then immediately, whether the patient looks fairly well from the end of bed despite their score, or very unwell, then I'm going to call the ITU intensive care registrar to come down and have a look at the patient and think about moving this patient up to a high dependency unit. Now they may score because of things in their past medical history that might mean that, well, their glucose is going to be a little bit elevated anyway because they're diabetic, or they've got a poor respiratory function to begin with. That doesn't mean that their score doesn't count. Of course, the fact that they've got these comorbidities mean that they're higher risk anyway. So we've got how the patient looks, well or unwell, but the score is also important whether they look well or unwell, because I'm going to know how early to escalate their care and how aggressively to treat them. Okay guys, here's a quick summary of what we've covered. Firstly, the functions of the pancreas, exocrine, endocrine, and also importantly acid-base balance of the blood. And then we talked about history and examination. So these patients have epigastric pain radiating through to the back, sometimes relieved on leaning forward. There may be some non-specific features such as loss of appetite, nausea, vomiting, that kind of thing. On examination, patients may look jaundiced. They will be tender in the epigastrium. Okay, there may be other features such as peritonism. They may be bloated, i.e. distended because of a coexisting ileus. Now, when talking about the investigations, there's the 6 tests that you need to consider for any patient with any condition, and in pancreatitis you generally do them all, okay? And then the other tests you need to know about, and that is ultrasound scan, are there any gallstones? MRCP, is there an obstruction of the CBD? Definitively, please let us know. And CT scan, generally not for diagnosis, but excluding other differential diagnoses, for example, perforated peptic ulcers. I'll say that again because it's very important. And CT scan for investigating complications if a patient deteriorates during their inpatient stay, to see, well, why have they deteriorated? Is there any necrosis, abscesses? And of course that brings us nicely onto complications, which could be local or distant. And to remember them, just think of different organs and that will help you gain some answers. And prognosis, then we touched on the importance of the prognostic scoring system. Now I've been talking about modified Glasgow score, but of course there are other scores that you can use. But as long as you and your team are talking the same language. So please leave feedback, thank you very much, and I hope to be making another tutorial very soon indeed. Bye bye.